What I'm going to do is talk about some selected pediatric, adolescent, and maternal abstracts that were presented at the last International Pediatric HIV Workshop and International AIDS Society Conference. And what we're going to start on is some studies on antiretroviral drugs in pregnancy. And the first study comes from Botswana, where they're doing a population-based study of birth outcomes. This is by Rebecca Zash and colleagues. And they abstract data from all consecutive births that are greater than 24 weeks gestational age at 8 maternity wards in Botswana, accounting for, I think, about 40% of all births in Botswana. And what they did was they compared about 4,500 infected women who started on efavirenz, tenofovir, and FTC during pregnancy and delivered between August 2014 and 2016 to 845 women who started dolutegravir-based therapy during pregnancy and delivered in November 2016 to April 2017. And around August 2016, Botswana changed its guidelines to have dolutegravir be first-line therapy in pregnancy, which is why they had this comparison group. They had a relatively small number of first trimester exposures, 116 dolutegravir, 396 efavirenz-based treatment, with one birth defect found that was in the efavirenz group, skeletal dysplasia. And this next slide really kind of says it all. The orange is the efavirenz-based treatment. The dolutegravir is the green. And you can see that there's no difference in adverse pregnancy outcomes between the two regimens for either any adverse outcomes, severe outcomes, preterm, very preterm, SGA, very SGA, stillbirth, neonatal death, or a birth defect. So this is very reassuring that there is no difference in adverse pregnancy outcome between the two regimens. The next slide is 3 additional studies that looked at birth defects with integrase inhibitors. The first 2 looked again at dolutegravir. The first one comes from the Antiretroviral Pregnancy Register, where they have 133 live births with dolutegravir exposure, 77 in the first trimester, 56 in the second and third trimester. And as you can see, there was no significant difference in the rate of birth defects between first trimester and second, third trimester exposure, 2.6% versus 3.6%. The next study from Claire Thorne and colleagues comes from the EPIC collaboration of 8 countries in Europe, where they report on 81 live births with dolutegravir exposure, finding birth defects in 4 of 81, or 4.9%. However, only 2 of these defects were really Eurocat-defined defects. For example, one was just hypopigmentation, which is not really a birth defect. So that really is 2 defects. So if you add together the Botswana data with the APR data and the Thorne data, you end up with 4 defects in 247 first trimester exposures for a rate of only 1.6%. So that's very reassuring regarding birth defects with first trimester dolutegravir exposure. The last study comes from the French perinatal cohort, where they looked at 479 women receiving raltegravir during pregnancy, and again report that there's no significant difference in birth defect occurrence between first trimester versus second or third trimester exposure, 5.7 versus 3.5%. So altogether, very reassuring data on integrase inhibitor use during pregnancy. So now we're going to move and talk a little bit about studies in pregnancy that looked at HIV care and retention. And this first study looked at women in a clinical trial that looked at integrated maternal-child health and antiretroviral treatment services, and looked at women who enrolled into the study, 486 women who were followed through 18 months postpartum. And there was transfer from this integrated care to maternal mothers getting their drugs through the general treatment clinic between 0 and 12 months postpartum. Unfortunately, only 55% of women successfully transferred to the antiretroviral clinic, as evidenced by post-transfer pharmacy refill. And if you look at the chart here, you can see that successful transfer was associated with older age, being married, multiparous women, an intended pregnancy, knowing your HIV status before the current pregnancy, and importantly, having more time in the integrated MCH ART clinic, which is shown in the figure on the slide. The next study comes from an NICHD-supported clinical trial in Malawi, looking at the effect of peer support. So this is a 3-arm trial that evaluated whether facility or community-based peer support by women who had recently gone through the PMT-CT program and were infected would improve uptake and retention of mothers and infants in the B+ program. So they had a standard of care arm that followed Ministries of Health guidance and used their cards and logs, which enrolled 447 women, and then a facility-based peer support group where they had peer one-on-one support at each clinic visit with weekly clinic-based support visits and contact of women within a week of their missed visits, which enrolled 428 women, and then finally a community peer support group where peers conducted routine home visits to provide HIV education, and they led monthly community-based support groups, and again women were contacted within a week of a missed visit for 394 women enrolled. And this next slide shows the results. The green shows standard of care, the red is facility peer, the blue is community peer support, and you can see that there was better uptake of antiretroviral treatment and better 24-month retention with facility or community support, the red or blue, compared to the standard of care, and you can also see that in the figure. And overall, there was better retention and lower default rates with facility or community peer support. Mortality, happily, was low in all of the groups. And while viral load was collected more frequently, viral suppression rates were similar in all groups. And that's not shown on this slide. It's just a result from the study. This next study comes from Nigeria, and it's called the MOMENT study, the Mother Mentor study, and it compared 2 cohorts of mother-infant pairs at the facility level, comparing the Mentor Mothers program to a routine peer support that was intermittently actually done. And you can see that early infant diagnosis presentation among infants by 2 months of age was almost 4 times higher, maternal retention and care over 6 months postpartum, 6 times higher, and maternal viral suppression at 6 months postpartum were 5 times higher with the Mentor mothers compared to the routine peer support. So now I'm going to move and talk a little bit about prevention of mother-to-child transmission studies. And the first study looked at the cost effectiveness of integrating maternal treatment into maternal-child health services. And this is the study that we talked about a little bit earlier in South Africa. This was a randomized trial where mothers were randomized to either routine care, which was separate maternal treatment, and infant care. So mothers went to an ART clinic for treatment and to a separate clinic for infant care, compared to integrated care, which co-located maternal ART and infant care in MCH services until the end of breastfeeding. And in this randomized trial, the integrated care improved retention and viral suppression at 12 months. And you can see that in the chart. Retention was 71% with routine care, 81% with integrated care. Viral load suppression, 49 versus 66%. Breastfeeding was longer in the integrated care, 6 versus 8 months. And there was a similar low 1-year transmission rate in both arms, 1.7%. So using this data and the cost of the integrated care, which was $200 per mother-infant pair, an analysis was done to look at the cost effectiveness. and that's shown on this slide. And this looked at the incremental cost effectiveness ratio, the ICER, which looks at the additional resource use over the additional health benefit and is reported in dollars per year life saved, which is usually compared to the per capita GDP of the country. So you can see pediatric outcomes were somewhat similar, but maternal outcomes in terms of life expectancy from delivery were improved. And this results in an ICER of integrated care compared to routine care of $1,000 and $1,050 per year life saved. And this is considered quite cost effective because it's less than 20% of the South Africa per capita GDP. So that when they did a sensitivity analysis to see what might change these results, they found that integrated care was increasingly cost effective with a longer duration of breastfeeding. For example, if breastfeeding duration was 12 months, the ICER was $990 per year life saved. Integrated care remained cost-effective unless the intervention cost greater than $2,360 per mother-infant pair, which is very unlikely because this is 12 times the estimated cost. And integrated care remained cost-effective even if the intervention impact on maternal retention and viral suppression was reduced by 50%. So this looked like a very cost-effective intervention to do, and effective intervention. This next slide looks at Swaziland household survey looking at 18 to 24-month HIV-free survival. So this surveyed all households with births between April and October 2013, a time when option A was the policy in Swaziland, and then looked at what was the outcome in terms of HIV infection and survival at 18 to 24 months. And you can see there were 2,000 eligible households. They consented 1,941. There was a 38% prevalence of HIV. 702 of 1,826 mothers were HIV positive. There were households in which the mother was not present and there was a non-maternal caregiver. And when the mother's HIV positive status was available on the ANC card and was positive, they had 59 mothers with 59 children, 3 children found infected. And in the households with biologic mothers, there were 643 HIV positive, including 35 who were newly diagnosed as HIV infected for the first time during this survey. Of these 665 children, 23 were infected, 4 had died. Just to point out that almost all of these women had attended antenatal care, and almost all of the women had received either AZT or treatment in 56%. And the overall transmission rate at 18 months was 3.6% on option A. And the next slide looks at the overall results. HIV-free survival at 18 to 24 months was 95.9%. Transmission rate was 3.6% in the known HIV-exposed children. And if one said that all of the dead children were infected, it was still pretty low, 4.1%. And the risk of child infection or death was significantly associated with maternal age. For every 10-year increase in maternal age, there was a reduced odds of infection or death. If mother received no PMT-CT drugs, there was an increased risk of infection or death, and delivery in a health facility was protective. Now we're going to move and talk about HIV diagnosis, both in infants and in testing of older children. So the first project is the Elizabeth Glaser Pediatric AIDS UNITAID project, which is implementing point-of-care EID in 9 countries. They had 2 different models of integration, both a central platform matched to a site or a hub and spoke model, which we'll talk about in a moment, and had a phased and monitored implementation, and they were reporting on interim data from 6 countries as shown on the slide. They collected pre-intervention data by retrospectively collecting data from the facility registers from a subset of intervention sites, 10 to 20 sites per country, to look at data from conventional EID. And then intervention data using point-of-care EID were collected prospectively using a specific testing form. And this slide shows the two models, the standalone model where an individual goes to a testing site that has a point-of-care test and the test is done there, compared to a hub-and-spoke model where individuals at clinics that are nearby but are small clinics send to a central point-of-care EID hub. And reassuringly, the data show that the testing results were similar between both the standalone and hub sites. So, for example, the percent of results returned to the caregiver, 95.5% with the standalone, 99.9% with the spoke sites. Median turnaround was only 2 days different, 0 days in the standalone model, 2 days in the hub and spoke. Turnaround to receipt of treatment in kids who were infected was 0 days, and the percent of children started on treatment was similar. So both models appear to be effective. And this next slide compares conventional to point-of-care EID, and you can see significant differences. The percent of results reaching the caregiver with conventional was 72% compared to almost 100% with point-of-care. The turnaround time from blood sample to receipt of results was 53 days compared to 0 days. Turnaround time from results to treatment was 0 days, and initiation on treatment was actually better in the point-of-care testing model, with only a slight increase in cost. And if one looks at the infected kids and compares the median days from the time the blood is taken to the time the child is started on treatment, there's a very significant difference, being 51 days for conventional EID and 0 days for point-of-care EID. The next study looked at the cost effectiveness of incorporating point-of-care assays into EID at 6 weeks. This used the Pediatric CPAC model and modeled this data based on the Glaser point-of-care testing data from Zimbabwe. And again, they looked at the ICER. And here were the assumptions that they used as an input to their model. Sensitivity and specificity, slight differences between the two. Cost $14.50 conventional, $21 for point of care, and result return time based on the data that we showed you before, 1 month versus 0 days, and the probability of linking to care, as we showed you before in the Glaser data, 71 versus 97%. And what they found was that there was a significant improvement in life expectancy for infected children because they were starting treatment earlier. So at 1 year, life expectancy was 71.5% in green for conventional versus 76.5% for point of care, with lifetime costs only being a little bit higher. And when they used this and did ICER, this was $750 per year life save, which is less than 1 times Zimbabwe per capita GDP, and therefore they concluded that this was cost effective compared to conventional EID. They also did a sensitivity analysis to look when point of care would no longer be cost effective, and that would be if only 75% or less of infants received results getting point of care, or almost all of the kids getting conventional testing received their results. If less than 80% of infants were linked to treatment after receiving point of care, you saw that that was significantly higher. If the assay sensitivity and specificity was less than 85 or 92%, or if the assay cost was over $40, which was significantly higher than it actually cost. This next study looks at older children. This is from Baylor, Uganda, and they implemented targeted HIV testing services for children and adolescents in 2016 and evaluated their testing yield. And they looked at 4 models: HTS outreach, which targeted orphans and vulnerable children; KYCS, Know Your Child status campaigns targeting children of known HIV positive index clients; targeted HTS outreach, which targeted high-risk groups, female sex workers, fisher folks, and tea plantation workers; and then finally evening HTS, which targeted youth by offering testing within the outpatient department between 5 and 7 p.m. So this slide shows you that over 4,000 children and adolescents were tested, about 52% female, 20% were less than 5, 30% 5 to 10, and 50% 10 to 19 years of age. And the little circle here shows you the numbers tested. So the highest amount of testing was done in the KYCS, 44%, followed by evening testing at 22%, and children of female sex workers, 15%. And if you look at adolescent testing by HTS model, you can see that evening testing was most effective in bringing adolescents to testing, followed by KYCS. And this next slide talks about reaching adolescents. So overall, 50% of those reached were adolescents in all HTS approaches, and you can see the most effective was the evening approach. 90% of those tested in the evening program were adolescents. Next most effective, HTS outreach to fisher folks, 48% were adolescents or children of female sex workers. And then this looks at the HIV testing by yield. Overall yield was 1.3%, was lowest in children 2 to 5 years of age, 0.4%, highest in youth 15 to 19, 2%. And this looks at yield by model and by sex. So if we look at yield by model, the highest yield was 2.6% in orphans and vulnerable children, followed by evening testing and children of female sex workers. And if we look at the testing yield by sex and models, you can see that HIV seroprevalence was highest among females, 1.6% in the pink, compared to males, 0.9% in blue. And this was particularly obvious in the evening testing that picked up primarily adolescents, 2.6% in females, 1% in males. This now moves to looking at testing through Elizabeth Glaser Pediatric AIDS Foundation, who supported expansion of pediatric HIV provider testing from 2015 to 2016 with a range of different types of approaches ranging from door-to-door, community campaigns, facility outreach, and tested almost 800,000 children during this time period. So during this time period, there was almost a 300% increase in HIV testing, a 60% increase in HIV diagnoses. However, as you can see from the graph, the rate of HIV positivity did decrease over time over these 5 quarters, and overall 1.2% tested HIV positive. This looks at the rate by age from 3 different countries, and you can see the lowest HIV positive rate was in children less than 4 years old, and this illustrates the effective PMT-CT programs that have been put in place in these programs, and the highest rate, not surprisingly, were in the oldest children, 10 to 14 years old. So this next slide looks at yield by testing point, but also by numbers. So if we look at the top, in Kenya, we can see in orange that the testing point that had the highest yield of HIV positive individuals was TB clinics, which is not surprising. But if you look at the bottom in green, you can see the largest number of children were identified through testing in outpatient clinics. clinics. So TB clinics, 9 to 20% HIV positive, but identified 40 children, while as outpatient, only 0.8 to 1.4% positive, identified 968 children. And so this shows you that while HIV yield should be an important factor in determining where you put your testing points, the absolute number of children identified is also critical, as these may not exactly match up. So this next study looked at community-based testing of children in Lesotho, which operated in 2 districts with high HIV prevalence and used 6 different testing strategies: mobile outreach clinics, targeted testing, community-based testing, facility index testing, door-to-door testing, and then finally door-to-door testing when someone in a household is found to be HIV positive. And this looks at the overall results. Over 47,000 children were tested. The yield was 0.43%. When they looked at the same district, same facilities a little bit later, the yield was pretty similar, 0.85%. And you can see that mobile outreach clinics in green accounted for the highest number, 48% of all HIV identifications. However, the yield was highest with index testing, either facility-based or door-to-door. And you can see that the rate there of identification was 0.6% and 0.83%, whereas the yield was less in the ones targeting high risk. So this is very similar to the Elizabeth Glaser data, showing that those sites with the highest yield may not necessarily give you the highest numbers, and you need to look at both. And this looks at, again, mobile outreach clinics, shown in orange, were most effective in identifying children of all ages, and that door-to-door testing was successful in finding older children, the children 5 to 14 years, if you look at the blue in the graph. And there were near even ratios among all age groups of female to male. This slide looks at prior HIV testing by age group, and the picture shows you in different colors. The color you should pay attention to is red, because red indicates the child had no prior testing. And you can see as the children get older, more and more have had no history of prior testing, and most HIV positive children over 5 years of age had never been tested before, showing that community-based testing was effective at finding HIV positive children, particularly older children who had not been tested. In this final graph from this study looks at linkage to care. They had a counselor accompanying the patient to facilities for most of these strategies. And if you look at the graph showing you retention by age, you can see that retention was best. Retention is green in children 2 to 5 years old, followed by 10 to 14 years old, and was lowest among those children 0 to 1 years old. So additional effort needs to be taken in that group. This next study looked at multi-month antiretroviral prescription in Baylor International Pediatric AIDS Initiative centers in 6 countries. The switch from monthly prescription to multi-month prescription was made on an individual basis based on when the provider viewed the patient to be clinically stable and adherent to antiretrovirals, which was typically 6 to 9 months after starting monthly prescription. And the group compared a retrospective review of over 20,000 electronic medical records comparing results for monthly versus multi-month prescription. Now, this comparison is somewhat problematic because those who stayed on monthly prescription stayed because they were felt to have adherence or clinical issues, but the important finding was that there was no adverse effect of multi-month prescription seen, and multi-month patients actually had decreased mortality, decreased loss to follow-up, increased adherence, and increased response to treatment as evidenced by CD4 and viral load measurements as shown below. So that's reassuring for multi-month prescription. This next study comes from the IDEA Southern African group, and they looked at pediatric treatment in South Africa between 2008 and 2013 in children who started treatment less than 12 years old, and they looked at temporal trends in infant characteristics and outcomes. And this table shows you that in children who were starting this young in different time groups, 2006 to 2009, when the recommendation was start all less than 1, 2010 to 2012, when the recommendation was start all less than 2, and greater than 2013, when the recommendation was start all less than 5, you can see over time that the children were being started at a younger age, a higher CD4 count, and an improved WHO stage and weight for age Z-score. So they were increasing their ability to start children who were less sick and younger. And this shows mortality and loss to follow-up, comparing these different time periods, with the red being the most distant time period, 2006 to 2009, black 2010 to 12, and blue is 2013 or greater. And you can see from these slides that the probability of mortality after starting treatment was significantly lower in the more recent time period, and loss to follow-up was also less. So they're doing a better job now. This slide looks at the one case that actually got the most press at the IAS conference, and this is looking at viral remission for 8 years off treatment in an early treated child. So this is a child who was enrolled in the SHARE trial of immediate versus deferred treatment. The child was DNA PCR positive at 32 days of age and enrolled in SHARE at 8.5 weeks of age, was randomized to immediate treatment with a lopinavir-based therapy and interruption at 1 year as per the SHARE randomization. And you can see the viral load was very high at initial diagnosis, became undetectable. Treatment was interrupted as per randomization, and then the child has been followed about every 3 months clinically and with viral load measurements, and you can see the child has remained suppressed off treatment with undetectable viral loads on standard assays for almost 9 years off treatment, has remained asymptomatic. However, they can still find a very low level of a viral reservoir, 5 copies of HIV DNA per million cells. The child does have a weak CD4 and CD8 response, and interestingly has a low CCR5 expression, which makes those cells less able to be infected by HIV, and low rates of immune activation. And clearly further studies are needed on this child, and there are at least 3 randomized trials ongoing, not randomized trials, pardon me, but trials looking at very early treatment with the potential for stopping treatment after 2 years of suppression with careful observation to look at whether this can be duplicated. Now we're going to move to talk about adolescents and HIV. This study looked at a study called POPARD, HPTN 071 in Zambia. And as part of this study, POPARD is a study that has intensive support and does household surveys annually to look at HIV prevalence and incidence. And here they looked at adolescents who were contacted at home and developed a screening questionnaire to be able to see whether they might be able to identify those at higher risk for being infected in the 10 to 14-year-old age group. The 4 screening questions were history of hospital admission, recurring skin problems, poor health in the last 3 months, or death of one or both natural parents, with a yes response to 1 or more questions being viewed as at risk. And so when they compared the records of the patients who were looked at and compared those who would have been identified at risk versus not at risk, you can see that those who were viewed at risk by this questionnaire had a much higher rate of seropositivity, 2.4%, compared to those who were viewed at not at risk, who had a rate of 0.6%. So the screening tool appeared to be pretty good at identifying youth who were at relatively high risk of being infected in this particular age group. This next study again comes from Pop Art and was looking at self-testing. So this was a 2-arm study in 4 communities in Zambia where they were allocated, randomized to either continue with the standard Pop Art intervention or offer a choice of HIV testing with an oral HIV self-test. And if you look on the left, the standard of care arm includes yearly universal door-to-door testing, service promotion with intensive referral for prevention, and universal treatment for all those who are HIV positive, facilitated by community health HIV providers. The intervention arm had these same interventions, plus offered the option of HIV self-testing, either supervised, unsupervised, and also offered self-tests to individuals to provide to other individuals, secondary distribution. And what you can see here is HIV self-testing increased HIV knowledge, particularly among men, younger adults, and those who had not previously been tested in the annual round 1 and 2 of HPTN 071. It was acceptable and there was no self-harm, and secondary distribution was feasible, and they said led to increased couples testing. So this is very encouraging regarding the use of self-testing. This next study looked at community-based support for youth on treatment with the goal of looking at effectiveness and cost-effectiveness of this large community-based support program for adolescents receiving treatment in South Africa. And it was a cohort study involving over 6,700 adolescents at 47 facilities, and they looked at facilities that had community-based support and those without it. And you can see from these graphs that loss to follow-up was lower with community-based support, as was mortality. And when they looked at the effectiveness, the cost effectiveness, the overall cost you can see on the left was $49.50, divided up as you can see, and cost effectiveness was very good. Community-based support was associated with substantially improved retention, was a low-cost intervention, had reasonable cost effectiveness, and it was maximally effective during the first 2 years of treatment. So you can see as it goes out, it gets a little bit less cost effective, but this is still cost effective compared to the South African GDP. And we're going to end talking about population-based HIV impact assessments via household surveys. So to better understand the current state of the epidemic, PEPFAR is funding these PHIA surveys, which are household-based HIV sero surveys that are planned to be done annually or biannually in countries. Between 2015 and 2016, Malawi, Zambia, and Zimbabwe completed at least 1 survey, and Swaziland has done 2. And this just shows you the 90-90-90 results from these 4 countries. And while we haven't reached 90-90-90 in all of the countries, you can see Swaziland is doing the best. The countries are doing reasonably well, and the big gap here is in HIV testing, having people aware of their status. And some takeaways from this, and I'll show you just some examples after this. In all countries, HIV prevalence was higher in women than men after age 14 years. In Malawi, they looked specifically at women and found women were doing better than men, but younger women, particularly those less than 24 years, lagged significantly behind older women. That the lowest 90-90-90 rates were in youth, 59, 77, and 79%. Pediatric prevalence was lowest among children less than 4 years, again evidence of a good PMT-CT program, but the lowest rates of viral suppression in these children who are infected and put on treatment is very poor, only 19%. In Zambia, the overall pediatric prevalence was 0.9%, again lowest in those less than 4 years, a good PMT-CT program, and again showed low rates of viral suppression in those that should be 0 to 4 years and 15 to 24 years. So the youngest and the oldest have the poorest suppression. In Zimbabwe, they looked at correlations of not meeting 90-90. So correlates of not knowing HIV status were younger age, male gender, never being married, and not using condoms in the last 12 months, the highest risk group. Correlates of not being on treatment, younger age, more than 2 sexual partners in the last 12 months, no condom use in the last 12 months. Again, a high risk group for transmission, not on treatment. And correlates of not having suppression, younger age, and male gender. And then finally, in Swaziland, they were able to compare their 2011 survey to 2016, showing a dramatic decrease in HIV incidence and an increase in viral suppression. And we'll just look at a few examples. These are data from the Malawi group, looking first at awareness of HIV status by women. You can see no one met the 90% goal, but the older women were getting there. But you can see in the red box, the younger women, 15 to 24 years, lagged significantly behind. If we look at self-reported treatment use, about 70% of the women reported being on treatment. Again, in the red box, the younger women, 15 to 24 years, lagged significantly behind. And then finally, if we look at viral suppression, overall 73% of women were suppressed, but again in the red box, these younger women lagged behind. This looks at pediatric HIV prevalence in Malawi. So if you look at the 10 to 14-year-old age group, this is a birth cohort from 2002 to 2006 who were around in the option A age of AZT, single-dose nevirapine, and the HIV prevalence in this group was highest, 2.1%. If you look at the 0 to 4-year-old age group, this is a birth cohort 2012 to 2016. The option B plus era, you can see significantly lower prevalence, 1.1%. You can see that the survey was very helpful in terms of showing where the highest concentration of children are in the country, with 70% of children living with HIV being in the southern zone. And then finally, you can see with viral suppression, there is a significant problem in the youngest age group. Only 19% had viral suppression, compared to about 50% in the older age groups, which is still not good. So we have a way to go to achieve viral suppression in younger children. This looks at viral suppression in Zambia. So this looks at viral suppression by sex and age. And you can see that the lowest rates of viral suppression were in children and youth, 0 to 14, 15 to 24, and that in the older age groups, between 25 and 44, women were doing somewhat better than men. And this, it looks at 90-90-90 by gender in Zambia. And these findings, preliminary findings, point to the need to increase testing, treatment, retention, and adherence for both young men and young women. And you can see in the 90-90 where the biggest gap is. Again, it's HIV testing, knowing one's status. And then finally, this looks at the Swaziland comparison of their FIA done in 2011 to their most recent FIA in 2016 to 2017, a time of universal treatment. And you can see that HIV prevalence, both in men and women, stayed relatively stable, 32 and 30%. But if you look at HIV incidence, you can see a dramatic decrease in HIV incidence over this time, a 44% decrease seen both in men and women, and actually was a little bit higher among men, 50%, compared to women, 38%. And when one looks at change in viral suppression, you can see a dramatic increase in viral suppression by over 100%, seen both in men and women, almost a twofold increase in men, and over a twofold increase in suppression in women. And so between 2011 and 2016, there was a decrease by nearly half in HIV incidence, a doubling of viral suppression, and this was true regardless of awareness of HIV status or treatment, and they felt was evidence for treatment as prevention at a national level. They've had good progress towards global 90-90-90 targets, and they have emphasize the importance of continued efforts to reach and engage men and young women in order to fully achieve the 90-90-90 targets. And thank you very much for listening. That's it.
Thank you, Lynn. Thank you for taking the time to do it again.
It's okay.